Everyone, and welcome to this special webinar series of 2025. I will introduce myself. I'm Etienne, a physiotherapist and rehabilitation specialist, and the current chair of Gene Africa. And before we go ahead, I would just like uh, to share this particular point. Please, if you are not speaking, just mute your mic. Secondly, your video can be off or on. It depends on you. And thirdly, this meeting is being recorded. Uh, I invite all of you joining or watching to for you at least watching here, I will share the link to Guideline International Network. If you're not a member, please feel free to look at the categories of membership and see where you can actually join. This is a fantastic network and platform for you to be. So today we shall be listening to our esteemed and reputable team from which will be led by actually Karen, Dr. Karen Deep, and presenters will also be Agnes Chisomo and Nanyonga Maika. Because of their extensive repertoire of experience and work they've done in this category, we can spend much time introducing them, but the summary of it actually will be shared in the chat. So if you want to know more about them, just look at the chat and then read about them. You can Google more about their extensive work that they are doing. So today we shall be listening to them and they shall be sharing their experience of developing guidelines and implementing pediatric cancer guideline in Sub-Saharan Africa. With that much please, Dr. Karin, have the stage.
Great, thanks, Etienne. So we are very excited to be talking to you today about our work, and I'm looking forward to the discussion afterward as well to hear what you've done as in this realm. So just to give you an idea of what we'll be discussing today, we're going to be talking about our Dissemination and Implementation Science, or DIS, Scholar Program. So essentially, it's a guideline development, adaptation, and implementation program where we discuss around capacity building around quality improvement, centered around improving the quality of care around children with cancer and blood disorders in Sub-Saharan Africa. So we'll talk a little bit about Global Hope, which is our program. We'll describe the program itself, and then give an example of one of the successful guidelines, and then I will transition over to my colleagues, Agnes and Mai, to talk about their project, and then we'll end with a Q&A session, and we have no conflicts of interest to disclose. So as I mentioned, we're going to be talking through at least the education program that I see my colleague Marilyn, Dr. Marilyn Hockenberry, has joined. And so we're really excited about the program. But first off, I wanted to give an introduction to Global Hope. So we are a partnership program. So we're based in Houston, Texas, so at Texas Children's Hospital, and we established Global Hope, which stands for Hematology Oncology Pediatric Excellence, back in 2016. And it has a number of initiatives, but one of those is the Dissemination and Implementation Science Core, which, as I suggested, builds capacity through education. And one of those education initiatives is how to develop and implement guidelines. Because I think, as many of us know, that there are some challenges with how we apply evidence in different settings. So the evidence might be consistent regardless of your context, but how we apply that evidence may vary given our resources and a number of different concepts. So as you can see, we have a number of partnerships across the continent, and many more in progress. And these are long-standing relationships that we've had with our colleagues to support cancer care. And so when we consider writing evidence-based guidelines for our context, we have within our network sites some, you'll hear me talk about PHO, it stands for Pediatric Hematology Oncology. So with our collaborations with our leadership, our medical leadership at those sites, we have prioritization of what topics, informed by M&E data as well, do we need to prioritize our topics. So overall, we have treatment guidelines, for example, how do you treat Wilms tumor, ALL, et cetera. And we have supportive care guidelines, which essentially support, as the name suggests, care around cancer treatment and beyond, things like nausea and vomiting, pain management, and wound care. And so the approach that we've taken overall is we adapt a lot of existing evidence-based guidelines and then support that with some focused searches for context-specific literature and make consensus recommendations outside of that, given our limited resources as a program and our very narrow application within our context for our network. And then when we create the guidelines, because we have a small locus within our network, we're able to also include education and order sets and roadmaps, any related standard operating procedures, or any other form of support to help implement the guidelines. So not just the development of the guidelines, but also to implement. And then one key piece that we have included is also a lot of support and education on how do you actually implement and the basics on quality improvement, and partnership with each of our network partners on how do you mentor and lead quality improvement projects within the various organizations, so that we can actually see the changes from the recommendations for each of the guidelines. So in the spirit of sustainability for the program, we know that we need continued development of both the treatment and supportive care guidelines within our context. And so in a lot of discussions more broadly, we talked about how we need to make sure that we build capacity to do this work within our network partners, that included not just cancer care, which we have our experts in our network sites, but also how to do guideline development and implementation science to implement these guidelines and develop them for our context specifically. And so what we created with my colleague, Dr. Marilyn Hockenberry, was the DIS Specialist Education Program, which is a series of education initiatives that build upon each other to discuss various components of how not only do you learn the basics of quality improvement, how to develop guidelines, and then how do you take them and learn more advanced phases of quality improvement to then implement them. And we aligned that work also to implement the current guidelines that we have. So you see here in this course structure, kind of the framing that we have for all of this work. So the first thing that we started off with was the basic quality improvement course. So this was a 6-month course that included both didactic and group project-based learning. And you can see some of the content included the model for improvement, how do you measure practice change, how do you implement, and how do you evaluate and sustain. And then we did, of course, the usual post course evals. And we created this through, I also have to give a shout out to Jennifer Higgins because she's wonderful, some open coursework through our QI courses that, again, all of this is specialized for our context within Africa. So all the examples are relevant for our context. To have the curriculum within Moodle so that people could take this, and then we supported it with Zoom sessions to help mentor them through their projects. And then from that, for each of those projects, we had a few that expressed interest or were nominated by their medical directors to take the DIS specialist guideline development course. And this was a smaller group that that we wanted to focus on the actual guideline development piece for the various network partners who might be interested in this work. Because I think for the guideline methodologists here, you know that it takes a lot of time and effort and some additional support to do this kind of work. And so this was another 6-month course that, again, paired the didactic content with project-based learning. And this is where, again, we have a lot of really high quality guidelines in our context. So we mainly focused on guideline appraisal with Agree To, using at least a framework of grade, and then grade development was where we focused a lot on how do we adapt guidelines to our setting and how do you contextualize this work. And then another key piece that we did was for leadership of how do you facilitate this work with a lot of different partners when you have all of your interest holders from different areas. How do you have those and facilitate those discussions? And then we did the post-course evaluation in both formal and informal feedback, since it was a small group. And so, like I mentioned, it was a small group, so we only had 6 students. We had some from Kampala and some from Lilongwe, mostly nurses and pharmacists. And then we had all of the guidelines were successfully completed. They went through our review process internally, and were quite a success. Overall, at least from our post-course evaluation, everything looked pretty positive as far as all of the assignments and the coursework, and preparing them to take this on in the future. I think that some things that were interesting were also not too surprising about the importance of protecting time, and then having to balance that with the clinical responsibilities. We did have some in-person sessions, and the project-based learning was helpful. And then I also wanted to talk a little bit about the transition from this into the advanced quality improvement course that we have, which includes the didactic plus project-based learning, but these are more advanced quality improvement skills. And so this one we're about to wrap up currently, but this takes it to the next level in terms of guideline implementation. So out of a lot of the guidelines that the teams developed, they are now implementing them at the higher level. So we're including a lot of more advanced metrics, more advanced implementation plans, and then how do you sustain? So a lot of these guidelines were much more complex. And so you'll hear a lot about that for the antimicrobial stewardship one shortly. And so kind of in summary, at least from the capacity building course, most of we had one, unfortunately, who left the organization, but a lot of them, I would say, were very successful in the work that they did, and we were very proud of the students that we had within the course. And this is a picture. Poor Agnes is not in this picture because she had to join remotely, but I think that one of the big takeaways here was that having that protected time for busy clinicians is a common thread, I think, for many of us, and how to balance those responsibilities and get that protected time is a major barrier. But also we've seen that the guideline adaptation using frameworks like Adolpment can be very useful for our context. And with that, I will transition over to Agnes to take over.
Thank you, Karen, and thank you for having me. I will go through the development of one of the guidelines that Karen has talked about on antimicrobial stewardship guidelines for pediatric patients in our setting. And As you all know that part of the pediatric oncology treatment includes different treatment options. And in those different treatment options that we have, especially in the African context, we use a lot of antibiotics in terms of treating different conditions such as fever and neutropenia, which is very common in our patients, in pediatric oncology patients. And we all know that there's a high risk for severe infections in these patients because of the different treatment options and also the chemotherapy that they are receiving. And as a team, we saw that there is an increase in antimicrobials, in the use of antimicrobials in our settings. And we thought of coming up with antimicrobial stewardship guidelines, which would help to decrease the antimicrobial resistance that is there in available in the different settings. Sorry, Karen, you can put on the whole slide. And our aim for this antimicrobial stewardship guideline was to optimize the use of antimicrobials as we saw that there was an increase of antimicrobial resistance in the different settings. And our plan was actually to create an evidence-based multidisciplinary guideline on antimicrobial stewardship interventions, especially in the pediatric oncology setting, specifically for the Sub-Saharan Africa setting. Through this guideline, we also intended to establish an antimicrobial stewardship program for Global Hope and under the DISCO program that Karen has talked about, and also outline recommended interventions and activities that we would take, and also that are evidence-based in order to improve the different outcomes and also ultimately reduce the antimicrobial resistance in our patients. And for this guideline, we did not cover clinical areas that were outside pediatrics, and we did not also cover areas that were outside of Global Hope. And to come up with our recommendations, for the guideline and through the guideline development methods and process that we used, we used 5 people questions that helped us and guide us to search for evidence. And we searched for existing guidelines and systematic reviews on antimicrobial stewardship in the pediatric oncology. And also, we went through the process of grading them and assessing and appraising them, as Karen already mentioned. And we did this using the Agree 2 checklist that helped us assess and appraise these different literature that we found in terms of antimicrobial stewardship, specifically for pediatric oncology. And we later on summarized the evidence, and this was done and reviewed with a multidisciplinary team, and we came up with recommendations through this process. And evidence from the guidelines and the systematic reviews was used to develop the recommendations. The recommendations were either adopted or adapted according to existing literature, and also according to different contexts and considerations, such as the evidence that we found, and also things like resources that we have, and also feasibility of how this can be adopted in the different settings. Our team consisted of pediatric oncology pharmacists and also different healthcare practitioners such as pediatric oncologists and the lab technicians and also the nurses. And we did our review mostly by meeting through Zoom, and some in-person meetings as well. And through the literature that we reviewed, and also some of the guidelines that we reviewed through this process, we came up with recommendations that spanned through all the activities that we thought were very important according to the literature that we had looked at. And things like we came up with recommendations and adapted some of the, adapted some of the recommendations or adopted them. And for example, we also came up with recommendations such as just us knowing that antimicrobial stewardship programs are very important in our setting, and also coming up with different educational materials to improve antimicrobial use in pediatric oncology. And we also came up with recommendations that also dived into activities such as surveillance and checking the patterns of the antimicrobials used in the different settings, and also coming up with other guidelines apart from the antimicrobial stewardship guidelines that could help improve antimicrobial use, such as fever and neutropenia guidelines, and how we can manage that to improve in a way that can improve antimicrobial use, and also ultimately the treatment outcomes of our patients. And lastly, we also looked at some of the importances of using audit and feedback from different stakeholders that would be interested in antimicrobial stewardship, and also some of the stakeholders that we can learn from in terms of improving the use of this guideline and also antimicrobial stewardship. And throughout the process, we learned that teamwork and also multidisciplinary work is very important to improve antimicrobial stewardship, and also the importance of adapting existing guidelines and existing literature to help us adapt or either adopt according to our context and also according to the resources that we currently have. And our next steps after the development were to actually through our quality improvement initiatives. And we first started implementing in Uganda at Mulago Hospital, and also we plan to do the same in Lilongwe at Kamuzu Central Hospital. This juncture, I would like to ask my friend Mike to continue with the implementation strategies that we have used for this guideline. Thank you.
Thank you so much, Aggie, and Karen, for the great presentation. I can't see my video. Is everyone seeing my video?
Yep, we see you.
Yeah.
Oh,
Can see it.
I don't know why I'm not seeing. I don't know why I'm not seeing myself.
All right.
Okay. So yeah. So yes, Aggie and Karen, thank you so much for that great introduction. I'm going to take you through the part of implementation of our antimicrobial stewardship interventions. Aggie has talked about how we developed the guidelines, and I'm going to basically be talking about the implementation part of it, where we basically focus on how do we put this evidence to practice, because the main challenge that comes up with research is we have all these amazing interventions, but then the question is, how do we actually bridge the gap between research and practice, which some people will basically call integrated knowledge translation, where researchers partner with the knowledge users who use these particular research recommendations in practice or policy. Okay, so basically the purpose of implementation science is to develop effective strategies for scaling up evidence-based practices, basically with the purpose of impacting policy, improving health outcomes, and improving patient care. Because, I mean, at the end of the day, it's an approach to quality improvement as well. Okay, so we also want to understand the different barriers, processes, facilitators that can influence implementation success for the future. And there are basically different theories and tests that we can use to also measure to advance this implementation science or our interventions. So this is a snapshot from Proctor and others who basically developed this conceptual model for implementation science research that was adapted for education. So you can see on this part, on the extreme left, we have our intervention strategies, and now we want to implement them, hence the big question of how do we do this in the first place with our, not forgetting the outcomes, implementation outcomes that we want to achieve, such as how feasible are these interventions? Are they acceptable in this kind of setting? Can we afford them? So basically, you have these different outcomes that we can still put into context. It can be healthcare outcomes, and this particular model basically looked at education, but you can still adapt it to other different projects. Yes, Karen, please go to the next slide. So there are very many implementation strategies that we can use to answer the how question of implementation science, okay? So this was a study that was more comprehensive that I chose to discuss with you, which is basically a study that expert recommendation for implementation change. It was an expert panel, basically, that used the Delphi design, different experts coming together and discussing about the different strategies that can be used for implementation science. And again, after developing these different 73 strategies, Dr. Waltz and others basically went ahead to further develop a short report that categorized these different strategies into 9 domains that I've displayed here, but we are going to really go into depth of a few of them, not all of them, that we use to implement our antimicrobial stewardship program. And again, I want to hint that these different strategies can either be used individually, or you can decide to blend them, which we basically did for our project. Karen, please go to the next slide. So having got the idea that we can basically use different implementation strategies, the question is now, how do you come to select that particular implementation strategy that you want to use? You have to think about things like the context. Implementation strategies are not a one-size-fits-all. So you really have to adapt that particular intervention to suit your particular kind of setting. You might either increase, adjust, and adapt basically maybe the audience, the size of the study, or even the culture. So if you think about your context, it's very, very important, and it can guide you to select the particular intervention strategies. Then we can think about the different theories or models and frameworks. We have very many of them, but basically these ones help you understand the logic of how that particular implementation effort creates an impact. It also helps you identify the different barriers and challenges that guide you to that particular intervention strategy that you have to use. Then the most important part is stakeholder engagement, which we find from the design of the research, and we are even seeing it when it comes to implementation, because understanding the different stakeholders will basically help you to identify what their priorities are. If you don't understand the priorities of your of that host population, you are likely to you are likely to want to implement a certain intervention that might not be acceptable in that particular kind of setting. So engaging stakeholders is important. If you think about resources coming together to work towards a particular goal is very important. And again, we'll see, if you think about a particular theory, for example, the diffusion of innovations, that's basically one of the theories that can be used to guide implementation strategies. And these innovations, what basically happens, you go into that particular setting, you are talking to the different people in that setting, telling them about this particular intervention. Hey, look, if we brought maybe a robot in your hospital to try and dispense, tell me what you think about it. You're basically trying to pick the minds of the people who are in that particular population to guide you whether your intervention will be successful, how you can easily adapt it to fit that particular setting. So again, it still comes back to stakeholder engagement. You can't basically do without it. Then again, we come back to the empirical evidence. What kind of evidence do we have? Aggie just talked about how we developed our guidelines. So again, the kind of evidence that you have can also take you in that particular direction of a particular strategy that you want to choose. And again, the question can be, how do we come to that particular implementation strategy? And these are basically just some of the examples. Formative evaluation, you can conduct a needs assessment to guide you. Again, I'll be showing you how we applied all these to implement antimicrobial stewardship at Mulago National Referral Hospital in Uganda, and very many other house approach, such that the concept mapping, which was used in the Delphi study, in the ERIC study, which basically used an ERIC approach, is an example. Karen, please go to the next slide. Thank you. So if you look at this particular approach, evaluation and interactive strategies, in Uganda and in Malawi, we basically conducted a SWOT analysis, and the purpose was to assess the readiness of the institution to implement antimicrobial stewardship. And on the right, these are some of the results that we got. It was basically qualitative interviews with local stakeholders, okay? We tried to pick our minds, and that one guided us so much on how to conduct the training that we will again see. We are going to appreciate the importance of stakeholder engagement. And again, like I mentioned, stakeholder engagement is very important. Right now, we are trying to implement, we are conducting a SWOT analysis, we are doing qualitative interviews, and in that way, we are already talking to the different stakeholders. Again, community engagement or stakeholder engagement is coming up here. Then adapting and tailoring to that particular context. Again, I'm not going to go into that because Aggie already mentioned on that, the different recommendations. Some of them we adopted, and others we had to adapt to suit our kind of context that we have. Okay, so during our SWOT analysis, okay, that's fine, Karen, that's fine. You can go to the next slide because we need to give everyone an opportunity to ask questions at the end. You can, thank you. So again, stakeholder relationships at the very beginning, when we had this beautiful idea, we had the guidelines, and now we are on the question of what do we do? How do we get this up and running? Global Hope is friends with Fleming and BD. So we try to engage them. You know, when it comes to antimicrobial resistance, you need to do culture and sensitivity tests, but that is a big problem when you come to our kind of settings. The culture bottles are really expensive. That's about $10 to $15 per bottle, which an underprivileged person might not be able to afford. So we reach out to Fleming, and we are trying to see how we can really pool efforts and collaborate. And Fleming is telling us, look here, we already working with Makerere Microbiology Lab, and they have all these resources that you need. So that is how we got in touch with Fleming, and now we are able to conduct some culture and sensitivity tests. So sometimes you can have the resources, but then you do not know where to find them. So you can see already the benefit of stakeholder relationships, how it was coming in here. Okay. And now we can see that the program, Omulago in general, is also collaborating with Makerere Microbiology Lab to see that we try to increase access to culture and sensitivity tests to our patients as well. Again, just to emphasize, it's not that Mulago does not have these resources, but sometimes when supplies run out, at least you have somewhere to fall back to. Right. So one of our strategy was to train and educate stakeholders. And this was basically an opportunity for training, because during our SWOT analysis, I got to realize that Mulago basically had an expert that Fleming had trained in antimicrobial stewardship. So that was like, yay, this is an opportunity for training. So we reached out to this person who was willing to do that. Okay. And again, if you find out that, okay, we need to educate, train and educate stakeholders, the question is, how do we do this? Initially, as the vision bearer, I thought that we would sit down and develop a training module and have people joining. But through interacting with people, they were like, we don't even have time for this. And the training material is already available. I mean, antimicrobial stewardship is not something new. So Fleming also had like a training opportunity. They have like an online course that people would, enroll for free. So again, us sitting down and developing a module would be a wastage of resources. So again, stakeholder engagement, we know that our people can basically access training at their own pace. And we also realized through the SWOT analysis, people do not really take antimicrobial stewardship or antimicrobial resistance as a global threat. So we're like, okay, how about we focus our training more on awareness and try to bring out the significance or the threat of antimicrobial resistance. And again, this was done through surveys and intervention and interviews and through observations. As we were moving around Mulago, you realize there was uncontrolled access to wards, and we are dealing with children with cancer who are immunocompromised. So we're like, that's a problem. We need a training on infection prevention and control. So that is one of the one of our presenters on that big day for training was basically an expert in infection prevention and control. So yes, Karen, you can move on to the next slide. Yeah, so this was the training that we basically conducted. It was more of an awareness training. We had 111 attendees, 90 in person, 21 online, and these included different healthcare stakeholders. And we had like a pre and post training to do an evaluation of the impact of this training. And basically 80% of the people who attended this training agreed that it was relevant. We had different approaches. We used Mentimeter, and through those interactions, we basically realized how terrible decision-making and antimicrobial misuse was really, really high. But at least from that training, it brought up the significance of implementing the antimicrobial stewardship, the importance of even continuous training, not just this one, which is one of the things we really hope to do in the future. Yes, Karen, please go to the next slide. So again, from that brief presentation, I want to emphasize that implementation can really be very complex and dynamic. So strategies might have to be adjusted. They might have to be modified as different barriers emerge. Okay, so these are basically some of the challenges that we found as a team at the time of wanting to implement this. And I just wanted to show you the example here. So initially, we wanted to focus our antimicrobial stewardship within pediatric oncology alone. And because this is like really a huge project, but during our interviews, that is when we got to realize, wait a minute, we are actually sitting within Mulago, a national referral hospital. So there is no way you can basically implement the antimicrobial stewardship program without thinking about Mulago as a national picture. So we really had to adjust. Our training initially was planned for a few people. We couldn't do this without thinking about Mulago. So we had to make adjustments to see how they really fit in. Again, during the SWOT analysis, one of the things that we realized was Mulago, as a national referral hospital, basically had an antimicrobial stewardship team, but it was silent. It wasn't really active. But through our continuous poking, personally, I went to meet with the medicines safe. The head of medicines and therapeutics committee, and he contacted the board. So it was really this silent committee that we sort of arose or awakened, and they humped onto the training. It was really very exciting. So again, you can see how their involvement had a huge impact on seeing that this training could really happen. Okay. So, and for some reason, me as an antimicrobial stewardship team lead at Global Hope, I got an opportunity to also be a co-opted member of the Mulago National Referral Hospital Antimicrobial Stewardship Committee. Then again, I think I already hinted on the training issue. Initially, we wanted to like just focus on training. What is antimicrobial stewardship? How does the resistance happen? And people were like, no one even has the time to like really sit down for the whole day to have this training. But us coming out and presenting children who are like really dying. We had like case studies, children dying because they had an infection that was maybe resistant to staph. It was a staph infection. It was resistant to all the first line drugs, resistant to PISA, resistant to meropenem, and the only active drug there in this particular case was basically tigecycline. It's not existent in the hospital. We tried to look for it, very expensive. Like we tried to bring up the real life cases, and everybody was like, oh my goodness, is this what is actually basically happening? So the awareness created more impact than what the previous training we had initially wanted to do. So again, the impact that this has on the hospital, on one of the trainings meetings as a co-opted member that I received, I noticed that there is this beautiful work plan that the hospital has, and there's been swabbing of different theaters to show what kind of resistant strains do we have. And they plan on making this really a continuous kind of approach that they take. So for me, I feel like this was really worth it because if you want to see these interventions really come to life, you need to target people who make decisions. And if the hospital is moving towards that, then I feel like the impact is really there. So yeah, Karen, I think that's the end of my presentation. I appreciate the opportunity. I'll give Karen to make her conclusion. Thank you.
Yeah, so thanks, Mai and Abby. And I think that, so just to kind of summarize everything before we go to the Q&A portion. So I think that they did a fantastic job describing their project and all of the just immense amount of work that it takes not only to develop the guidelines, even the adapted components of it, but for how much time and effort that it takes to then implement them, but really how much you get on the other side from seeing those, all that work, you know, as a methodologist and a nurse, of seeing how, you know, we write guidelines, but we rarely get to see them put in practice, and how fruitful it can be when we pair the guideline adaptation work with the actual implementation side of things. So when you put them all together, it's really, really powerful. And so as far as the next steps, at least for the antimicrobial stewardship work, like Mai mentioned, of all the continuing work for not only growing that as a, not only within the, you know, PHO and within, you know, the cancer center that we have, and we, like she mentioned, the and that Agnes mentioned, we have the fever and neutropenia work, which is a very small subset within the broader antimicrobial stewardship work, that we have projects going on, again, within the bigger DIS scholar education work. But we also have, you know, broader sustainability to think about, right, when you do quality improvement work longer term, but that it's a much bigger picture, as Maya had mentioned, when you think about things that are going on not only within regional networks. And then Agnes was just mentioning about how they're going to be implementing in Lilongwe in February from the training perspective, and kicking that off, and how much time it takes to, you know, get everything aligned, and making sure that you have all of the powers that be ready to go. And then from the capacity building perspective, we're just continuing to support and trying to make sure that we provide what's needed from an educational perspective to support the current projects, and seeing where that needs to go, and making sure that we align with that. So I know we have about well, of course we have to do references because we're those kind of people. But I wanted to open up for any questions, either in the chat or otherwise, if you want to.
Well, thank you so much for your presentation. Thank you. That was absolutely fantastic. Thank you. Yeah, you can put your question in the chat, or you can actually unmute yourself, put it up with your hand, or unmute yourself if we are not so many, and ask your question. So if you're available, you can unmute. I think, Patrick, you have a question.
Hello.
Hello?
Hi, I had a question. First of all, great presentation. Very interesting stuff. I'm curious about these technology tools that are being used in the process of developing these guidelines, because I'm actually Wellcome Trust is working on a very interesting AI tool called Destiny, and I'm actually part of that. And this AI tool is meant to create a comprehensive repository of academic papers, and this repository is going to be constantly updated. I feel like a similar approach could be used in managing the pediatric cancer care guidelines. And in fact, there's a resource called OpenAlex that has a vast data set of academic publications. You can use the API from OpenAlex, which is what Wellcome Trust is doing, and you can use it as a resource to source guidelines if you are going to develop a tool for this. So basically, my question is, are you thinking of any technological way or any technological tools that will ease collecting the guidelines and developing them?
Yeah, that's awesome. I was like, I wrote those down because I need to go look at those. I know that for our program, we have an internal, you know, collection, at least for our guidelines, I think the bigger challenge that we have found is that in order for them to really be integrated into the processes for each of the sites, is that all of the hospitals have their own unique policies and procedures and way in which they get integrated into the actual practices of the hospital. And my colleague, Dr. Anna Kulo, she's at in Mulago in Kampala, Uganda, at the JCRC, but she has been working with each of the different hospitals to actually get them integrated into each unique site's policies and procedures to really make sure that they get into clinical care. But I will definitely take a look at that and explore it a little bit further to see if it's something that we can learn more from and connect
Thank
with.
you so much. Thank you. I think, sorry for cutting you. Yeah. First of all, I would also like to invite anybody who have any interesting work going on around Africa that would like to share on this platform. You are free to contact us, and then we can arrange and you can do a presentation. Okay. I think I will, Patrick, I know you've put so many points, but can you just hit on one point and then let the answer be a bit punchy so that we try and catch everything, or a couple of things before we end the session? Please
Okay,
go ahead, please.
thank you very much. I will have to prioritize. I think it was a great discussion, and I'm always very impressed. I think it's a wonderful thing you've been able to roll out to have all these webinars, because the tendency is always that nothing is really going on in the African region except the use of essential medicines list. But from the past two webinars, we can see that quite a lot of high quality work is ongoing, and we need to start speaking to them. And I have 4 questions there. I don't know which one to prioritize, but Karen, I need us to talk about working with some of the network of our hospitals in Cameroon, especially for the oncology guidelines. AMR is a problem as well, but I think the oncology issues are the things that we would like to take up. I'm sure either myself or one of my team members will reach out to talk more about that. But then also, I may want to just add a last one. Considering the expertise of your team in Delphi surveys, the scoping review we are working on will guide us for developing a Delphi survey that we will want to do later to talk to experts in the guideline space. So at that point, we'll be happy to use some of your expertise. Thank you.
Okay. Any other question? Or, Karen, would you like to kind of just react to that in a bit?
Oh, yeah. So I don't think we used a Delphi survey. That was just one of the tools that we could use, although I think that Agnes and Mike could speak more to it. I have done them in the past, and those are a really useful tool, particularly for more challenging discussions and how to facilitate those in terms of prioritizing different components of this, but this kind of work. But just some of the other points that I just wanted to speak out a little bit is we have a number, and I saw at least one of the other members, Joanne here too, but we have a couple of different quality improvement initiatives that incorporate some form of audit and feedback in terms of different initiatives that we have around quality improvement work, in terms of, are we meeting goals in the communication with teams? And I think it very much so depends on for every organization and where they are, at least in their quality improvement journey, and the culture of safety and the culture of quality improvement within that organization, in terms of how that sort of feedback is received, in terms of how those discussions go and how to report data in terms of the audits, either individually or group, reported as a group and whole. And so that's been a fun journey, I have to say, to discuss things over time. And we've been able to get a really good critical mass of education around quality improvement, at least within our small group of PHO. And I think our network has been really, really fun to work with. So we've had a good time.
All right. Thank you for the response. Since there's no other question, let me ask a couple of questions just briefly. One, I think this might go to the other presenters, but to your team as a whole, I've seen from the presentation that the implementation was done in Malawi and Uganda, if that is correct. Was it done by the same team? And did you observe some particular facilitators or factors that actually enhance the whole process or make it, like not too long over a period, or some specific challenges that we should be aware of if we want to actually kind of replicate that? And then the second question is, in your guideline implementation, have you actually, in the clinical space or through that process, realized that this, let me take the aspect of rehabilitation, where somebody is really like 2 week, that you think, yeah, there should be referrals, and maybe any other intervention could come in place that will enhance overall health or outcome that you think should also be prioritized and perhaps a guideline developed so that it can enhance practice. Thank you. So, yeah, anyone can go ahead.
Aggie, do you want to take that?
Hi, I think I can answer on that one, especially on the first question, and on some of the challenges that I'll start first with the team that was involved, and also how we tackled some of the challenges that we had. And I think from the presentation, we did involve, it was a multidisciplinary team effort. So we did involve most of the health practitioners in our setting, for example, the physicians and also the lab technicians, just to help and come up with information that could help us and guide us in our coming up with the recommendations, or also just having an overview of what of where we are at in our antimicrobial stewardship programs in our setting. And one of the challenges that we had is the fact that we did not, there were poor communication lines in terms of our setting, the way some of the way the communication lines are set up in the institution. So, for example, what Mai had mentioned, that antimicrobial stewardship is not a new topic. So the first thing that we did was to have a situationship analysis, where we had to look into the setting and see what do we have already at the moment and what are we doing about it, and on those. So I think the challenge was trying to bring in all different teams together so that you can actually do one thing and not maybe, for example, repeat one of the other things from the different departments, for example, in our setting. So I think that's one of the things that we did, was to first have a situationship analysis and see what do we have, what are the people that are available, and what are the gaps that we can fill in for that. And in terms of the overall interventions for implementing the guidelines as to help the treatment outcomes of our patients, I think that is just one of the things that we think, or one of the things that could help treatment outcomes in our patients in the pediatric ward. But there are other interventions that also we think could be very helpful. Like, for example, what I mentioned, that having other guidelines, for example, fever and neutropenia guidelines, to help come up to help with the treatment outcomes and to help with the treatment outcomes of the pediatric patients. So I think those are some of the interventions that we think could actually help with treatment outcomes, and not only just the guideline, but also involve other teams to come up with a consensus on what is best to come up with the best treatment outcomes that we can for our patients. So I think maybe Mike would answer the other question, but I hope I have answered the question on the challenges.
Okay. Yeah.
Yeah.
All right. Yeah, briefly go ahead, please.
Yeah, I just wanted to emphasize on what she said, and also, like when I was mentioning, stakeholder engagement is really important, and most of the challenges that Aggie has hinted on, the solutions have really been through engaging different stakeholders, like the training one I shared. So it's really a paramount approach that you can take to find a solution in case any of these problems arise. Yeah, thank you.
My God. Thank you so much. And we look forward to sharing your experience in the subsequent phases of your program. And thanks. I really want to take this time to say thank you to every person that attended. And our next webinar will be on the 20th of February. And I'm looking forward to having you. And if you do have more exciting topic, please feel free to reach us, and we'll definitely plan and conduct the dissemination process, because this is also part of the dissemination. So thank you to everyone, and we'll end the webinar here now. Thank you.